right, everybody, we'll go ahead and get started so we can stay on time. Good afternoon and welcome to today's session of how GetWell Rounds Plus can improve efficiency, compliance, and SHEP and sale measures. My name is Stephen Bankston. I am the Senior Client Services Manager for GetWell Network. During today's session, our presenters come from Hampton VA Medical Center. They will share their experiences on Rounds Plus. Today, they'll speak to you all about discovering the many ways in which the VA Medical Center has incorporated a digital rounding tool into the clinical workspace to improve real-time service recovery, operational efficiency, and organizational compliance. The aggregated data is used to assess veteran and staff responses and perceptions, as well as monitor environment of care, infection control, and event site preparedness of regulatory survey visits as well. Also, improving workflow integration and breaking down barriers will also be covered. It's my pleasure to introduce you all to the presenters. Bridget Carstens is the nurse manager of the intensive care unit and step-down unit at Hampton VA Medical Center. Mrs. Carstens has over 23 years of experience as an RN, nine of those years as an ICU, and over 12 years in management. She has served in many different avenues of nursing, such as starting her career on a medical surgical unit in upstate New York, to serving as the director of nursing for a registered nursing program, which led her to Hampton VA in April 2017. LaDonna Stone is a licensed clinical social worker and is currently serving in the role of Customer Experience Manager at Hampton VA Medical Center. She began her career at Hampton VA Medical Center in 2015 as HUD-VASH social worker and was promoted to Customer Experience Manager in January 2016. LaDonna's 15-year experience spans across many settings, including working with children and families in their homes, homeless shelters, outpatient clinics, mental health agencies, DOD, community health centers, and currently at Hampton VA Medical Center. After hearing from our presenters, we will open the floor for questions. Before we get started, I need to share a disclosure statement with you from the Maryland Nurses Association. The Maryland Nurses Association is an accredited approver of continuing nursing education by the American Nurse Credentialing Center's Commission of Accreditation. If you wish to receive credit for attending this activity, you must complete the session survey found on your conference mobile app. In the survey, it is important that you check the box indicating that you would like to receive credit and enter your full name and email addresses in the space provided. Your certificate will be sent to that address. In compliance with the Continuing Education Activity Credit Conflict of Interest disclosure requirements, we'd like to announce that the presenters of this session have no commercial association that would create a conflict of interest. Bridget and LaDonna will both kick off.
Good afternoon. All right, so I am LaDonna Stone, again, Customer Experience Manager. I oversee our patient experience initiatives. I supervise our patient advocates and have been heavily involved in the implementation of Rounds Plus and the GetWell Network Inpatient solutions. So this is an overview of what we will be discussing today. We will be talking about the identified opportunity, the project overview, the process and workflow of how we got everything situated and implemented, the feedback that we got from both our veterans and our staff, our outcomes, and then, of course, our next steps. So starting with the overview of the Hampton VA Medical Center, this is a lovely picture of our campus, very beautiful. We are located in the Eastern Virginia location, and we also serve some of our veterans in the North Carolina area. We have 4 sites. Hampton is our main site, and then we have 3 outlying clinics. One is in North Carolina, Albemarle. Then we have one in Chesapeake, and then one in Virginia Beach. And I don't know if anyone's familiar with we're right here. Everyone should be familiar with this area, but it's the Hampton Roads area, or 757. All right, for those of you all who are familiar with the VA system, you all should know what our mission is, but we are here to honor American veterans by providing exceptional health care that improves health and well-being. All right, so the GetWell Network partnership. We said I do 2 times. So the first time we said I do was in fall of 2018, and this is when we actually rolled out Rounds Plus. So we rolled out Rounds Plus with another VEO initiative, which was our We Care Leader Rounding, and I'll talk a little bit more about that as we move on.
And then in the background, while that was kind of happening, while we were getting our feet wet with GetWell, we were trying to bring the whole with Rounds Plus, we were trying to bring GetWell up on board, which was kind of a long process in my opinion. She's telling me to, hold on, I gotta turn it on. Am I on now? Keep talking? Can you hear me? Uh-oh. She's gonna come play with my butt. Keep talking. So, that was kind of a long process because we had to, am I good now?
Not yet.
Because we had to, of course, get all of the equipment up and stuff. And, of course, that wasn't easy because, you know, we can't close beds and we couldn't move patients. So I was telling the team, hey, bed so-and-so's open, so come help us. So, but we finally got it going.
All right, so a little bit of background information. With me working in our patient experience office, I get feedback all day. So being able to receive feedback was never an issue. We had very plentiful avenues of getting feedback. So I don't know if you all are familiar with Press Ganey, but this was a tool that we used to use maybe 3 or 4 years ago. Of course, SHEP, we learned about that. Our patient advocate tracking system replacement, for those of you all who are familiar with our patient experience world, then some of you all may know what that is. But ultimately, that's our documentation system that we use in our office to document concerns, inquiries, complaints, and compliments. And then social media, we have telephone calls, we have walk-ins, and then we have our comment cards. So being able to get feedback was never really an issue. What we identified is that we do not have a way of getting systematic feedback before the veteran comes to us. So we identified that we need to be a little bit more proactive with how we're receiving that feedback and try to forecast what we may think will be an issue before the veteran comes to us with the issue. And with that opportunity, we decided that we need to be a little bit more proactive and adaptive. And so with us being able to utilize Rounds Plus, we were able to, one, find or leverage technology. Before, when we were using or going out doing our rounds and getting that feedback, we would have a piece of paper, which some of us still do that now, but we have our piece of paper, our pen. Our leadership would go out and they would do rounding, and then the rounding papers would come back to me, and I would sit in my office behind my desk, and I'm typing all of this feedback in. There was really no streamlined way of really being able to fully capture the data and make it meaningful so that when I'm reporting it back out, people know what to do with it. We were operating in a very reactive manner. We were waiting until there was an issue, waiting until the veteran decided they want to come to us with the issue instead of us going out to them at the point of care.
So then came across the idea of being flexible. Healthcare being flexible, right? Let's dream world. We're really getting close though. And responsive and adaptive. You know what I'm saying? If you have a patient that comes in that has an issue, take care of the issue right there on the spot. I know I can remember when we first kicked off Rounds Plus, I would come around and a veteran would say to me, well, I don't know why the nurses won't do X. And I'm like, oh, okay. So then what would I do with that? I would go back to my team and say, okay, what's going on here? And we really found problems with processes. We found problems that I didn't, as a nurse manager, have a clue that was going on. But the veterans were feeling it, and the staff was feeling it, but we had no way to find it out. So being able to bring that forward definitely helped us. Organizations, as it says up here, need to go beyond clinical practice and adjust quickly to patients' needs because they have a need now, not 2 days from now or 3 months from now or whenever we get the results back. We have a problem now that we need to deal with. And then we need what we're using to kind of flex with it. As a government employee and as a nurse, being flexible in healthcare, you're kind of locked into policies and procedures. So make the policies and procedures work not only for the facility and the staff, but make it work for the veteran at the same time. I love that picture. So the whole idea here was to improve perception. Because, like we were talking about earlier, then I hear my nurses across the hall teach about patients' meds all day long. Like some of the girls, they say it almost verbatim. I could probably sit in my office and mouth with them what they say. But then the veteran gets to those PXP questions and they say they know nothing about their medications. Or you get to discharge and they're like, oh yeah, I know, because what do they want? They want to sign that sheet and get out. So that was helping us. But it gave us the ability to go around and see these problems. Not only that, it helped with upper leadership is now doing rounding too. My staff was they were like, wow, upper management is coming around and talking to the veterans. They're talking to us. Everybody's listening to what everybody's got to say. I know when I go out and do rounds for the veterans, they'll say to me, wow, you're asking me what I think about something. And I'm like, yeah. And what's really nice is when they can say, well, I have this concern. And I can say, you know what? I got it. And then I can come back in a couple of hours and have a solution for them. That right there is priceless. You can't fix that. Because guess what? If they had that problem and then they go home and they stew about it, what happens? They're going to fill that SHEP survey out. They're going to be the one.
And then I'll get it. And then I'll share with everyone what our veterans are saying.
and then it's lost. Can you fix that at that point? No, you can't back it up. Real time, we're in the moment. We're actually, in a lot of the situations that I see, we're actually ahead of the moment. Because we're catching it and asking them questions, which makes them think about what's going on before it even happens, before it gets to the point that it's got this ugly little monster. There's a good Bridget and a bad Bridget. You got to watch that bad Bridget because sometimes, man, she gets going. So if we can kind of flick that one off of there and get the good Bridget working, we're golden, right? That's kind of the thing. So then we take all of this data, and thank God poor Miss LaDonna doesn't have to put it all, every time you say that, it just kind of boggles my brain. But we do actually sit down and look at it. And I know on my deck and on the MedSurg tele unit, we sit down and look, and we've adjusted processes in our workflow for the staff. And they think it's great because they get to fix problems too, because guess what? They're fixing things with patients. So if a patient's happy, who else is happy? The nurse, which is a golden thing. And then, of course, we're really close to showing that one of our CHF pathways is actually decreasing readmission rates. So it's getting close. So we're hoping that that's going to come about too. So just talking and listening to people, communication. We're so digitally these days that communication doesn't happen, in my opinion, like it should. So this also gives us a voice, and it gives them a voice to be able to say what their problems are or their concerns. So I'm a nurse. Everybody sees Ad Pi up there, right? How long has it been since you've been in nursing school? Don't answer. But that's what we really had to do. We had to treat this like a problem because we had to find the solution. So what were our issues? One of the biggest issues that I was seeing was education or lack thereof. Somebody may have had a diagnosis for 20 years, but they don't know how to do an inhaler right. I mean, how many times have you seen an asthmatic go, too many to count, right? Same thing with everything. Oh yeah, I got it. Same thing with the meds. I got it. I know all about diabetes. Been diagnosed for 20 years. Hemoglobin A1C is 14. Okay, that's not working. Do you know what I'm saying? But see what we can find. So we knew education was a piece. And then for the facility, it was that real-time feedback. You know, SHEP surveys are great, but what do we get them? 3 months later?
Yeah.
4 months later?
And there's no comments on the SHEP survey, so
Right.
for those of you who are familiar with it, we get numbers, but sometimes really what do the numbers mean? If we're trying to drive improvement and change behavior, you need more than just sometimes a number in order to do that. So this gave us the opportunity to actually get that real-time feedback.
Yeah. So we asked, what are our weaknesses? And we figured those out. So then we had to make a diagnosis. What was the diagnosis for the facility going to be, and how can we fix it? Meetings, can I tell you meetings? Numerous meetings. But big thing is who do you bring to the table? Everybody. Everybody. The more people that you can get on board when it first starts and they get the taste of it and see what's coming forward, definitely builds it forward for you in the long run. Because I'll tell you, you're going to lose people along the way. Trust me. I think it's me, LaDonna, and a couple more left out of like 20. But that's okay because we just keep pushing. And then they get ramped back up again, and then they dwindle off, and then it gets ramped back up. But that's with anything, right? But you just got to remember, bring everybody, even if you don't think they're involved. I remember when we first started, EMS was like, why do I need to come? Well, they know now because they're getting those questions that, hey, somebody needs to come dump my trash. You know what I'm saying? It's great. I like it. And then we started using, we had been using the Rounds Plus to kind of gather data and stuff from not only veterans but the employees also. And then we implemented GetWell. Evaluate is still a work in progress. We're going to get there one day. I always hope for a perfect world. I don't know if it exists, but I hope for it. Next slide. So there's a small snippet of my team. Somebody asked earlier, I was talking to somebody, they'd been voluntold to get the GetWell Network up on prep, so there's my team. And it really was everybody. Biomed, why does Biomed they still need to be involved. Medicine services, surgical services. Forgive me if I offend anybody, but surgeons, you just have to grab them by the ear and bring them to the meeting to make them understand. We had dialysis on board and chemotherapy because those are our, two of our outpatient units that actually have GetWell, so we definitely wanted them on board. OINT, God love them. Chaplain services, and it's really worked out well. They use a lot of our processes, and people can order from their bed if they want to see the chaplain, which has really worked out nice. EMS that I talked over earlier, and then our poor nurse informatics, I think she hates me on a daily basis, but it's okay. So this is kind of a short, sweet, and to the point slide that makes all of that work that we did look very nice and pretty. And it wasn't that bad. It was just, I think in my opinion, it was tedious. And we were doing a lot of work in the beginning, but we weren't getting any gain from it. Because you've got to build all this. You've got to individualize it around your facility. What is your problem at your facility? They can't just say, okay, here it is. Because if it's not hitting your problems, it's not going to help you. So training, training, training. And then technology training, so more training. And my nurses are so over me they could scream. And then we finally went live, so we could finally put it out there in front of the veteran and get some feedback and see what they were thinking about it. And I'll say it if I haven't said it 1,000 times. The number of veterans that say to me, thank you so much for coming to see me. You took time out of your day to come see me. Like I think it's what makes me go to work every day, because all I did was stand in front of them for like not even a minute. And they are appreciative of it, so it is definitely a good thing. And then, of course, in the beginning, we did weekly meetings because we were still trying to bring everybody together, and we were still building to see what did we want to do with it and where did we want to go forward.
So how many of you all are familiar with the We Care Leader Rounding? Okay. And at the Hampton site, what we did is we brought in our what I call it the big VEO team. So we brought in big VEO, and they came down and they did a session with us on how or what We Care Leader rounding really looks like. So ultimately, for those who are not familiar, you have your leaders, program managers, anyone who leads a program, supervises an individual. You have them involved in this rounding. You have set questions that you have each leader round. So there's this systematic way of rounding. And then you go to a service that is not your service. The concept behind that is if you are leading a service, you have a program, you should probably know what's going on in your own service. So the goal is for our leaders to be more visible, to get out and hear what's really going on. Because ultimately, the way that the structure was set up, LaDonna was the main one who knew what was going on throughout the entire facility because I'm literally touching every service, whereas some services may be only touching 3 or 4 other services on a continuous basis. So this was a way for our leaders to really get out and hear, one, the voice of the veteran, and to hear the voice of our employees. So for those who are also familiar with our big VEO, this should be very familiar. This is also something else that we utilize in some of our other trainings, but this is pretty much our framework. In the middle of this framework is what our veteran experience and our employee experience. We really need both to be on the same page in order for us to see improvement in both areas. So when you look at this framework, you see that we talk about people, culture, and processes. So utilizing technology to do what we were kind of already doing, but probably not in the best way, helps to engage our leaders, and it helps to engage our employees. Our culture, kind of what Bridget alluded to, I should probably use this now. So what Bridget alluded to is we have to know our culture. So what works for Hampton, what does not work for Hampton. So while we had the big VEO team to come in and show us what We Care Leader rounding is, I still had to adapt it to what works for us. Once we got Rounds Plus, I was so ecstatic because I no longer needed those pieces of paper. I no longer needed to sit behind my desk for a couple of hours to put all this information in an Excel spreadsheet. I tried to learn Access. It was not working. I was not able to really use the information or the data. So it's almost like we're asking our leaders to do this, but what are we gaining from it? What is the point? You have to garner buy-in. So Rounds Plus, being able to actually have this technology, this tablet walking around, capturing the data at the point of care versus this pen and paper. So just moving from some of the dark ages. But we really had to focus on what our culture was like. What are our leaders capable of doing? What do we have time to do? And what is going to work for Hampton? And then focusing on processes. So once we actually start hearing the voice of the veteran, hearing the voice of our employees, what are we doing with that information? So the goal is to not just capture the data, capture the feedback, but it's to get that information and then report it back out and say, what are we going to do about it?
Yeah, that whole thing makes me crazy. That data-rich, action-poor, like it almost makes me want to jump out of my office window. And by the way, I'm on the 3rd floor, so it probably wouldn't be a good idea. They'll be putting me on suicide watch. Another component that we do, and I think a couple of the people talked this morning, is the PXP questions through GetWell. So our patients are asked about discharge and room cleanliness and pain and staff responsiveness. And I'm going to tell you a funny little side note. So last night, LaDonna and I were talking about this, and I was like, you know, I haven't seen any PXP questions come through. I haven't seen anything come through. Are we sure that I'm getting the responses? I'm like, this is really weird. What do you think was in my inbox when I went upstairs to my room? 3 emails from 3 patients, or 1 patient, from 3 questions from 1 patient. I was like, oh, well, that works. So luckily, my staff that is back at Hampton, they also got the emails, and I texted her today and said, hey, did you check in on this veteran? She goes, yep, email already sent. Then she goes into Rounds Plus, comments through the PXP, and we close the loop. You know, before we would get a patient would have a complaint, and most of the time, one of LaDonna's team would come and talk to the veteran, and then they would come and talk to me, Uh-huh, uh-huh, uh-huh. I would go and talk to the veteran. What happens after that? What happened after I made my veteran smile? Where does that data go? Poof. It goes to the land of never, never. But now we can put it in Rounds Plus, and we can go back and we can track some things. And I've actually seen myself and the nurse manager for the med-surg tele units have seen some trends that we've drilled back to staff, that we've drilled back to processes, and we've fixed those moving forward. So now the data is being captured in the process so we can actually use it to move forward.
And
Sorry.
yes.
What questions? You can't talk until you got a mic.
Hello? Okay.
There you go.
Who actually has the iPads? Like, who did you
We'll
give
get there.
them to?
We'll get there.
Okay.
We'll get there. He's coming.
So for those who may not be familiar with the PXP, which is our patient experience pathway, these are the questions that we focused on, and we really tried to focus on questions that were related to SHEP, so that way we can see if we can drive improvement through SHEP. For those of you all who were in one of the discharge pathway sessions that was talking about the GetWell Network, whenever you're trying to utilize surveys on site and you want to utilize SHEP, you cannot use their questions verbatim. So while these questions correlate, these are not the exact questions from SHEP.
So where was the advantage for doing these rounds and stuff? Not only did we get the negative viewpoints from the veteran, we also got the positive viewpoints, because what happened to those? They definitely didn't get back to the staff. So every time I went to a staff member and I was like, I could never come to them and say, yeah, you guys did a great job. It wasn't there. And then even if I talked to a veteran and went back to them, I had nothing that I could send forward to leadership and say, hey, look what my staff did. I'm a little competitive. So it was nice to be able to have this platform to be able to put it in. We also use it across the outpatient setting. Actually, Rounds Plus is through our entire facility, even in our outpatient clinics. So everybody kind of has a piece of the puzzle to that. We were lucky because our ad pack was behind us 110%, and she says, you will round. So everybody says, okay. Well, what was that? That was change. So then when they did that, we had to show them what is the benefit. Well, I don't know about them, but I know in my office, it's decreased the number of complaints that comes from her office, because guess what? I'm taking care of it right here before it ever gets out to her world. We also started doing some staff rounding, which found some things that, I don't know about you, but I have a couple, not very many. I'm an ICU nurse, so my nurses are very, they tell me what they need and what they want now. So what we did is I started seeing every staff member. So those quiet ones that you never heard from, that's where your best ideas come from. So now we were individually talking to all of these people and document it, and then what we did was we would, at the end of the month, I bring this information back and they take it to shared governance, and then shared governance team ramps it up or decides what we're going to do, positive or negative.
All right, and so that I won't forget this piece, with our Rounds Plus, with the We Care leader rounding, I was able to set it up to where if I go to a unit, so say my service is scheduled to round on the ICU unit, and the veteran answers a question in a way that we would really want them to say yes to, but they actually said no. There was a way for us to set that up to where an alert would go to that service, so that way that service can see what those responses are and then be able to use that to actually drive improvement. So with the Rounds Plus tools, it's more than just putting the data in the system. There's ways to actually leverage it and make sure that those who need to be involved are involved. So as far as the process and workflow, when we initially got the We Care leader rounding put in place, remember I said that we were using the pen paper, using Excel, or LaDonna was using Excel to put all of that data in. I would do my weekly reports, monthly reports, but I really didn't feel like it was really getting us anywhere. And so once we actually decided that Rounds Plus would be a good platform for that, I was able to get tablets. And so the tablets are located in our Veterans Experience office. They can get checked out by leaders. And what would happen is the week that our leaders are scheduled to round, should they choose, because not everyone still wants to use the technology, some still want to do the paper and pencil, but majority of our leaders, they would check out those tablets from the office. They would actually go to the unit that they are scheduled to do rounding on, document the rounds immediately, so that way when they're done, they're done. They don't have to go back to their office and input it in the system. So when we talk about culture, I knew that if I wanted to kind of garner buy-in, I had to find as many ways possible to make it a little bit easier for our leaders, because we know if you work in the VA system, you're never not busy. So any way that we can garner buy-in. With regards to utilizing GetWell Network on the inpatient unit, so again, we had to get other folks involved, so I had to set up email distribution groups through our IT team, which is pretty easy. Just ask for, put in a ticket, ask for some email addresses. And for those questions that you saw earlier where it talked about responsiveness, doctor communication, and things like that, what we did is we spoke to the staff. We generally were using our service level liaisons and our clinical nurse leaders. Those are the individuals that are behind those email addresses. So that way, if someone happens to say, no, I do not feel like the staff responded quick enough, then whoever's behind that email address will be the one to check on our patients. With the questions, we have communication-related questions, so doctor communication, nurse communication. If it's a no to doctor communication, then we have physicians that respond to that. Nurse communication, of course, we have our nursing staff. And then the question that focuses on room cleanliness, then we have our EMS staff that will follow up on those. And ultimately, what's happening is when our veterans are completing this PXP survey, we have it set up to where it shows up on the first full day of admission, I think right around 11 o'clock. They have the opportunity, they do not have to take the survey if they do not want to, but when they do take the survey, they answer those questions, and we have it to where if they, again, answer no to a question we want them to say yes to, it alerts our staff members, and then they come to the room to address those concerns.
So this is one of the biggies. As somebody that's worked in what I call civilian hospitals her entire career and now has come to the VA, got to be careful what you say. So we do have to be careful with using patients' names. I don't think I would use a social security number, but we definitely don't want to do that. And what they've done as a reminder is they, in the Rounds Plus, they have put a red statement. Now, I don't know about you, but you know, things that are always there people ignore. But the red definitely, I mean, like you can't help yourself but to read it because it's red, I think. But it does definitely work, and you just need to be careful with patient information here.
All right, so regarding our feedback. So again, with me working in the patient experience office, sometimes I don't need to do rounding to kind of know what's going on, because again, I'm in the business to where if veterans have concerns or compliments, they're gonna come directly to us. So even though we're trying to leverage a system where we are more proactive and go to them, we still will have veterans that will come directly to our office because we just cannot capture everyone. So based on some of the feedback, some of the common themes that we notice is that when our veterans actually get to see whomever they're there to see, whether it's their provider, their caseworker, their social worker, that they're satisfied. Once they actually get to that actual person, it's kind of the things beyond or before that that kind of impacts their experience. And then our veterans are satisfied that they're being asked for feedback. So again, this is a process of us coming to them versus waiting for them to come to us. They weren't used to that. They were used to, if, say for example, one of our SHEP questions, if you had to wait more than 15 minutes, we would put signs up that says, if you haven't been called within 15 minutes, come to the desk. Well, no, how about we come to you first before 15 minutes and say, you know, this is what's going on. That's us being more proactive versus reactive. And then some of the things that we would hear, parking. I don't know if parking is great anywhere. If it is, please let me know so I can bring this back to our facility. Access. So unfortunately, our sites is one of the sites where we do struggle with some of our access, and so that would come up as a common theme. Again, didn't really need to utilize this platform in order to find that information out, but it gives us a better opportunity to hear about what they feel their access issue is, whether it's related to can't get through on the phone or can't get an appointment when they want to, or if they have multiple appointments, are they able to get all of those appointments in the same day because it's just more convenient and makes more sense. And then sometimes our veterans do hesitate to share feedback. Some of our veterans, they feel like they don't want to get someone in trouble because they think if they share feedback about something, then we're gonna, point our fingers in our employee's face, and that's really not the case. So sometimes our veterans, they really hesitate to provide that feedback. With regards to staff, recognition of other team members, so despite whatever challenges some of our teams are facing, a lot of our staff really like the people that they work alongside. And a lot of our employees are very motivated to help solve issues. So generally what I'm doing is at the end of every month, I'm going through all of the data, I'm looking at every question, printing them out. Forgive me, I use a lot of paper, even though this is supposed to be technology, forgive me. But that's the best way for me to really kind of look at the information that's being put there, and I compile all of that together to kind of identify what those trends are, and our staff have really, really great ideas. And if we're not like asking them these questions, I don't know at what point it's gonna come out for them to say, hey, we need to do this. And then again, for staff, parking is an issue for them as well. So of course, that's a common theme. And again, some employees hesitate to share feedback as well. So that's something, of course, culturally we need to look at as well. One of the other things that I wanted to mention too is with our feedback, what we do is, as I notice trends throughout the facility, sometimes our questions will change to kind of mimic what we're trying to maybe improve on. So the good thing about this is the questions that you set up, of course, does not have to be the end all be all for those questions. So what I've started to do is every quarter to maybe every 6 months or so, I may change one question. For example, we rolled out something called the Ask Me 3 initiative. The reason why we rolled that out is because it focuses on communication. Communication is a huge driver for improving our inpatient setting and some of our other SHEP and SAIL measures. So by me being able to ask that question, first finding out whether or not we did a good job with educating our staff about what Ask Me 3 is, and our veterans, are we talking to you about what Ask Me 3 is? So this is a way, one, to make sure that what we're pushing out, we feel like we got people that understand what's going on and why we're doing what we're doing. So as far as the outcomes, we did approximately 2,038 patient rounds. They were completed. So prior to us formally utilizing Rounds Plus, I started at the start of the fiscal year, so October 1, 2018. However, we were doing some of the We Care leader rounding prior to, but since utilizing Rounds Plus, we were able to complete 2,000 patient rounds. Again, veterans reported seeing and feeling a change. And we saw across that time span improvement in half of our SHEP measures. And one of our greatest improvements was on our care transition score, where when we initially started off, and who's familiar with SAIL? Okay, so SAIL is pretty much a rating system of how the VA system rates ourselves and essentially against each other. And so for our quintile improvement, 5th quintile is not good, and 1st quintile is excellent. So for our care transitions, we were able to move from a 4th quintile all the way to the 2nd quintile, and we're just steadily moving up. Some of our other measures, we were able to improve percentage-wise, but it was not great enough to move us out of a particular quintile because, of course, when we do great, that means someone else has to, unfortunately, not do so great. And if we're not moving really, really fast, then sometimes we can see improvement, but not enough to get us out of those quintiles. So we really saw some improvement with that on one of our inpatient measures.
So some of the big things which is really a key to success is the staff. they're encouraging the veterans to participate. I have a thing where, when they're going around to do their 9 o'clock meds, the staff says to them, now don't forget to do your questions. They're going to come up. And if you need help, you let me know and I'll come help you. We've really tried to get them because the majority of my population in ICU is spinal cord injury patients. Kind of hard for them to answer questions on the GetWell Network. But they have no problem ringing the doorbell. Listen to me, ringing the call light so they can get some help to come back and do that. And the nice thing is they can learn at their pace and in their time frame. You come into the hospital and you get this new diagnosis and you're like, ugh. And then we're like, okay, and you got to watch this video and you got to watch this video and here's a handout for this and here's a handout for that, and they're like, ugh. But the next day, they kind of come around and say, okay, we got to figure this out, especially the family. I come in and teach a veteran on day one about X, Y, and Z, but none of the family is there. None of the caregivers are there. So what information have they gotten? Well, they got a piece of paper that you hope they can find when they get home. You know what I'm saying? But it was nice to be able to, there's 3 rooms across from my office that it's like, I don't know, whatever they say in those patients' rooms, it like swirls around in my office. And I heard a family patient the other day say to his wife, hey, I watched this really good video. We really need to watch it again so you can see the information. I was like, oh. So it does happen. Lessons learned, reinforce. Gentle reminders that they will do X, Y, and Z. And inspect what you expect. Man, like one of my nursing instructors would have been so proud of me to say that. She used to say it all the time. I'm going to come and look. Okay, we're going to come and look. But really come back and look and see. Look at that data. Bring the data back to the veterans. Bring the data back to the staff so that they see that you're actually doing something with it. And I'll say it again. Data rich, action poor makes me crazy. You've got to do something with all that we've got. And then, of course, share the results of the questions that you're seeing. What did you say the rating was, 9.7?
Yeah, so the data that I pulled for the PXP surveys each month, the highest rating is a 10. And I want to say from the 2 units that we utilized that on, or the 3 units rather, the lowest score that we got was a 9.7 out of 10 for all of those 5 questions. So we're doing fairly well to have used that for those veterans that are completing the survey.
Mm-hmm. So what's next? Reinforcement, re-educate, remind. And train additional super users. I don't know about at your facility, but my staff kind of ebbs and flows. Like they change departments, they're kind of all over the place. So we initially started out, I had 4 super users. I had 2 on day and 2 on night. So I have 2 day teams and 2 night teams, and my goal was to have a person from each team, and it actually worked out. But I've lost a couple of those people. So you definitely need to make sure that you keep training your super users, because somebody's going to get to a point where they can't figure something out. And 2 brains is always better than 1. And of course, develop additional pathways. We've got quite a few, and I hope Stedman's not listening, but we want some more. So it is definitely a bonus to be able to, when that patient comes in, have that automatically kick off to the patient, so they have this little, video selected for you. It makes a difference. It's all about the verbiage of what you say, so it was definitely nice to be able to say that.
And that is it.
I think that's it.
Do you all have any questions for us? Yes.
Of course I do. So when you do the rounds and you score it, does the score go into the management console for your score with the PXP?
Yes.
Now, what happens if the veteran potentially can be scored twice then?
So when I look at that data, I can see exactly who or which room completed the survey, the time that they completed the survey, and if I see that it's happened like literally back to back, because once they do one survey, they can hit the button for it to pop back up again. And so if I see that that's happening, then generally what we're doing is I'm reaching out to the nurse manager to say, hey, this veteran just completed this survey, multiple times. Someone may want to go in and check and see what's going on. So ultimately, it can skew the data if the veteran just decides to continue to do that. But if you have your alerts set up, it should stop immediately once you notice that second email came through.
So on the tablet, on the Rounds Plus, you can see that patient in 150 already completed the PXP questions while they were in the bed.
Oh, no, I'm sorry. I misunderstood that. So no, if I'm coming to the room with the tablet to do the rounds for the PXP, then no, I don't see that they already just completed it on the actual GetWell.
So the veteran or whoever, the patient has a chance to do 2 scores
Yes,
then.
yes.
So they could cancel each other out or
That's true.
elevate the,
Yes.
okay.
Hi, I'm Tisa from VADC. I have a quick question in regards to your experience on patients who are not able to do the evaluation, like altered mental status or dementia patient, because it populates every 4 hours or 2 hours, like if their pain is well controlled or not.
Right. It is. It does make things difficult. What I've encouraged my staff to do is if we have, if it comes up on the screen, and sometimes they can toggle it and get and answer questions, and you kind of scratch your head, and sometimes you have to go back and check. But most of the time, I encourage the staff, if they're in the room when it comes up, to get to the family member to help the veteran with the questions. Sometimes you get caregiver feedback and not veteran feedback, but at the end of the day, we really need feedback from both. So it's hard with that, especially with the dementia population.
Yes, because in our experience, most of them doesn't have any families. So it pops up like every 2 hours. And he will say that it's happy face or sad face.
Mm-hmm. Yeah, it's the staff on my unit have been encouraged to help them with that. And to see where they are as far as pain. Of course, on my unit, everybody's on a monitor, so I can look at blood pressure, I can look at pulse, I can look at all of these other things that like the med-surg tele unit doesn't have right at their fingertips. But we do try to help the veterans with those answers. But you're right, and a lot of my population is either from our community living center or our spinal cord injury unit. That's the reason my ICU exists, is for those 2 populations. So if we really took those 2 populations out of the picture, it would probably drop my population in half, at least. So it is a concern. And like I said, if you've got caregivers that come in, and sometimes guess where the caregivers are? It's the staff from the CLC or the spinal cord injury unit that are coming over to visit. And sometimes they'll also, they've been shown because one girl came over and she says, "What is this?" Because they don't have GetWell over in their community living center or their spinal cord injury unit yet. I say that like almost shards of glass out of my mouth. It really needs to happen. But so they will help the veteran get those questions asked at that time. Is that what you're asking me?
So I have a question about, just to clarify, the questions that you've set up are shown to the patient at set intervals. So every patient on your unit gets shown the questions and has an opportunity to respond.
The PXP questions
Yes.
through GetWell, yes, sir.
Right.
All of every patient gets the same questions through either in ICU and step down or up on our med-surg tele unit.
And how does that dovetail with the leader rounding? How frequently does that occur with the questions that they can answer every day?
So the We Care
Yeah,
Leader rounding, that's something that we do on a weekly basis.
Okay.
And those questions may not mimic the PXP questions, but our We Care Leader rounding questions are still designed to reflect how responsive we are, whether or not we're making our veterans comfortable. So we're still utilizing some of our SHEP-related questions, but it does not mimic that, so that way it doesn't kind of
Okay.
survey our veterans out, if that makes sense.
Sure. And on that same line of questioning, so when you're looking at leader rounding, do you round on every veteran or a subset of the population? Like, how do you try and get as many veterans as you can?
So our inpatient solutions, they're primarily rounding on majority, if not all patients. For the We Care leader rounding, we're only set up to round on up to 2 veterans.
Okay.
But when you have all of your services, all of your leaders doing it, we're able to kind of capture a lot of veterans. But the We Care leader rounding, utilizing that tool, we're only, whatever unit we go to, we're only going, well, not going, but we're only rounding on 1 or 2 veterans.
Okay.
Inpatient is going to be way more.
Okay. Thank you.
Yeah, my veterans, I talk to my, well, if I can, talk to, my veterans. Of course, if they're on the ventilator in my unit, I can't. Sometimes they can communicate still on the vent. I got some ones that'll be going one for yes and 2 for no. It works. But I have a small population, so I'm able to round on all of my veterans. And then, of course, I also round on every staff member once a month.
And for our, we do have the GetWell Network on 2 outpatient floors or units, so dialysis and chemo. But we do not have those PXP questions pop up for those veterans, but we still have that rounding tool to actually go to those veterans and utilize the questions that way.
Hi, my question is that how was the process of building the Round Plus forms? Do you only use it for leadership rounding, or you use it for other rounds?
For other rounds also.
Yeah.
Like yesterday and the day before, I got emails from the Community Living Center and then also from an outpatient clinic saying, these questions really aren't hitting on my issues. Can we change them? Of course we can. So we can, we can kind of change the questions to hit your problem so that you can drill down and try to see if you can figure out the answer. So you can change the questions. I mean, it's very adaptable to what your issue is. Like LaDonna was saying, in the We Care rounding that leadership does, she changes them about once a quarter. I have my emergency room, when she was really trying to drill down and find some stuff, she changed questions 3 times in a quarter, because she wasn't finding the answer. And finally, the 3rd time was a charm, and she found out, where the problem was, and it was actually a process, and that was fixed.
My other question is for staff rounding. Do you also have a set of specific questions?
Yes.
Okay, so similar to the leadership.
Yes.
All right, thanks.
Yep.
And then you can create as many surveys in the system that you want. Just make sure your staff knows which survey to use for which purpose. So it's a great tool. I think we had, maybe 18 or so up at one time, so that way each individual leader, if they wanted to do a little bit more drill down and have it actually captured, so they can pull the data, the graphs, all of that is already there for you. We kind of drilled down a little bit on that, so that way it wasn't too confusing, but you can literally create as many, unless there's a cap. I don't know if there's a cap. I don't think there is, but
We've
you
pushed the
can-
limit.
You can create as many as you need for whatever that purpose is. And especially if you're trying to do a pilot and you need to capture data, it's excellent for that. So
I have a question about the rounding. You said that you have leadership rounds and you have the tablets, and you said the nurse managers have the tablet. When they ask the PXP question, and let's say they say the room isn't clean or whatever, and you give it a negative score, an alert automatically goes to
The
EMS?
the PXP questions are answered through the GetWell Network on the TVs by the veteran.
No, I get that, but I
Okay.
thought you said you also ask questions like that when you round.
Very similar, yes.
Right, but if it's a negative response, does an alert go to EMS or the housekeeping
yes,
automatically through
Yes.
email?
yes.
Now, you said you closed the service recovery to that. So does EMS have tablets too? So when they go to visit that patient to say, what can I do? Do they have a tablet to close the loop? How do they?
They have the opportunity to sign the tablets out if they want to. Mostly what I'm finding is, for example, if they come up to my unit, they'll come up, they'll talk to the veteran. Then when they get back to their office, they will chart it in the system then.
In the round system? Okay,
in the
I
Rounds
missed
Plus.
that part.
Yep, in
Okay.
Rounds Plus,
So
yeah.
that's how they can do it. Okay, thanks.
I think I heard you guys say that first I'm Erica, DCVA. You said you share the results with the veterans?
With
Did you
our-
say that?
With our leadership.
Just with the leadership?
Well, depending on the forum, so with me having access to like patient orientation and things like that, I create a lot of educational materials. And so sometimes the data that we get back from that will be put on like an educational, I guess one pager is what I call it. When we have our veteran town halls, information is feed that way, but there is no other formal method that I actually share that data. The only formal method is gonna be with our employees and our leadership. So even though I share with the leadership, I send the email out to all staff and it trickles down. All leadership, forgive me, and then I ask that they trickle it down.
On the administrative side, who builds the surveys? Have you controlled it just to your team, or I don't know how cumbersome it is. We're just starting to get into Rounds Plus. Are there other experts within the organization for other surveys, not specific to, say, patient experience? Maybe it's CAUTI or CLEPSI or hand hygiene. Do you have other people building surveys?
Yeah, so we actually had a team that helped us kind of show us how to create the surveys, how to set up the alerts and things like that. But there are pre-populated surveys that are already in there. So if you need to we even have surveys in there for like environmental care or things like that. It's already pre-populated. If those questions don't work for you, you can edit those questions and or create your own.
And the nice thing about the pre-populated ones, at least it gives you a place to start. You know, and you may ask the questions, and after you read that through the questions, and you're like, oh yeah, that's great, and you get to the bottom, and you're like, oh yeah, that didn't work. Let me rephrase this because it's not getting what I need. Like I was saying about the ED nurse manager, she kept changing her questions because she wanted to know where the actual problem was. But our infectious disease nurses actually have CAUTI and CLAPSI evals that they do.
All right, any other questions? Okay, thank you all.
Thank you.